The Five Pillars of Occlusal Diagnosis, An Introduction to Clinical Dental Metrics by Francis J. Stapleton. Hi, I'm Frank Stapleton, a general dentist practicing in the New York metro area for the past 30 years. I would like to share with you some of what I've learned over that time with respect to restoring or developing healthy dental occlusions. In providing full disclosure with respect to some of the equipment I'll be talking about, you should know that I'm not a paid endorser. I do not receive compensation in any manner. In my early practice, perhaps like you, I spent many years in continuing education courses, clinical trial and error, and just banging my head against the wall when things didn't work out. But I was lucky in that eventually I came into contact with many clinicians and educators who provided me valuable understanding of the problems we face on a regular basis. In this presentation, I hope to put these pieces of the puzzle together into a comprehensive thesis that may provide greater insight to your diagnostic and treatment planning process. This talk will seem to focus on some very advanced technology, but please understand that this program is actually all about the data. Starting now and into the future of dentistry, data will be king. And fortunately or unfortunately, depending on who you are, this endeavor will require both advanced technology to gather and advanced technology to interpret this data. Like our medical colleagues, it will be the job of the dentist to understand what information is needed, to assess data relevance and integrity, and apply the appropriate information to our clinical challenges. Today we will be considering 5 relatively new technologies needed to collect and analyze the information critical to understanding dental occlusion. I like to call these technologies the 5 pillars, in that the information they provide lends support to the diagnostic and treatment planning process. Old paradigms rooted in dental technology have failed. They are mechanical and not based on human biology. Dental anatomy must be understood in relation to the more primary neural skeleton, not the temporomandibular joint. This survey will cover information as it is typically gathered. As such, we are first interested in structural or cranial base analysis, how are teeth related to the neural skeleton and in particular portions of the trigeminal nerve. Before the first tooth is ever touched, we must know about temporomandibular joint function. Are we dealing with A, a normal adapted joint, B, one that is compensated, or C, a joint that is now decompensated? The status and integrity of the joint has profound implications on both mandibular posture and function. We need to know how and to what degree the joint is damaged. Electromyography is critical for the evaluation of the neuromusculature. Nerves provide the electrical activity to operate muscles, and muscles move bones and joints. Spastic and hyperactive muscles may result in pain, dyskinesia, and abnormal mandibular posture. Surface electromyography, in both rest and function, gives valuable information about health and pathology. Assessment of the musculature can also help in differentiating extracapsular from intracapsular problems. Unlike clinical palpation, computerized electromyography provides information that is objective and can be stored for future analysis and comparison. Serognatography, or computerized jaw tracking, tests the resultant function of normal anatomy versus acquired pathology. This technology not only provides useful information on functional health, but can also be an important instrument for use in establishing a therapeutic mandibular position. T-scan is a device that brings life to the marks that articulating paper create. The pressure-sensitive ink contained within the thin plastic wafer transmits information that is displayed and stored on the computer about the force and timing of tooth contact. Never before has information on where, when, and with how much relative force are the teeth meeting ever been understood. This device is excellent for the determination of occlusal timing, disclusion timing, and the center of force assessment. T-scan is useful for both evaluation and treatment of occlusal contact issues. There are 9 dental specialties, but in reality only 2 types of dentistry. tooth dentistry, and mouth dentistry. Ultimately, every dentist must decide on the level of their practice. Undergraduate dental school education provides basic knowledge for the practice of tooth dentistry. Mouth dentistry requires more than just education. Of course, you need a higher level of education, and lots of it, but mouth dentistry requires a commitment to excellence. Any dentist that has been practiced for even a few years appreciates how mistakes made early in the restoration process become amplified out of proportion by treatment's finish. With that thought in mind, realize that for complex treatment to succeed, the diagnosis needs to be both accurate and complete. Better information should yield a better diagnosis. A better diagnosis brings a better treatment plan, and a better treatment plan, better treatment. There does seem to be some consensus on how teeth should meet, though more in the realm of anthropology than dentistry. Our problem is that dentistry's traditional paradigms of occlusion are technique and articulator based. The technology we've had to study dental occlusion in the past was, at best, flawed and inadequate. As a result, the profession has had no unifying theory as to how dentists should engineer an occlusal treatment result. As true today as when Dr. L. E. Johnson, Jr. sarcastically noted many years ago, "Gnathology is the science of how articulators chew." Sadly, even today, most dentists' concept of how the stomatognathic system operates is pretty much modeled after how articulators work, or more accurately, do not work. Where does the clinician on the path to occlusion enlightenment look? One problem we all face is that advanced dental education is not without politics and commerce. It is the natural order of events that the thought leaders on this subject look to maximize profit in delivering their message. Whether selling a simplified ethical technique for obtaining an occlusion, or a more scientific technique that is based on incomplete cookbook methodology, dentists search and pay dearly for guidance, often to receive an education more tailored to be measured in someone's profit than clinical success. In this presentation, it will be assumed that the audience understands how to run a dental practice. It will assume that this practice is run in an ethical manner, and that the Hippocratic oath of do no harm is supplemented with Google's mission statement of don't be evil. Stripping away the economics of technology allows us to focus on how new instrumentation facilitates better ways of examining human biology. This trend is inevitable. You need only look to see what's happening in medicine. The future of dentistry will not be ruled by technique, but rather it will be more real science-based and driven by data in all respects of practice. As the pendulum swings and dentistry becomes reincorporated back into medicine, let me ask you this question. Has there been a time when you've gone for a medical examination that you did not have your blood pressure taken, blood drawn, and urine analyzed? How did you and your physician know if everything was healthy? The answer is simple. If the results of your tests conform to the norms and you are without complaint, well then, see you next year. In today's dental practice, how much clinical data is developed on our patients? Do we conform to the medical model, or are we practicing more like the prophets of Piss of old? The obvious conclusion leaves a bad taste in your mouth, but for different reasons. How responsible are patients to understand the limitations of treatment? When was the last time someone asked you if that filling was permanent? Having clinical data can define expectations for both clinician and patient. I'm going to ask you to leave your concepts and baggage at the door. Enjoy learning about new technology, and try not to get ahead of me. Understand that learning about something new subjects you to the Kubler-Ross model, commonly known as the 5 stages of grief. You will first want to deny that this new information is true. Anger follows denial. Next, in an attempt to integrate and accommodate this knowledge, bargaining with old concepts occurs. You may actually become depressed in that what you once knew and loved has been replaced. And finally, new ideas become accepted as the norm. This is the nature of progress. Cranial-based diagnosis. What is it? Why is it important? Before I answer this, let me acknowledge that I stand on the shoulders of giants. In this talk, I will attempt to give credit where credit is due. Simply put, the pieces of the diagnostic puzzle are not original to me, but the synthesis and overall concept of how they relate might be my contribution to progress in this area. I first learned about the importance of the neural skeleton from two teachers, Dr. Melvin Moss and Dr. James Carlson. Dr. Moss taught of the primacy of the nervous system in growth and development, and Dr. Carlson wrote and lectured about a simple but powerful articulator. Just to stop you from what you might be thinking, what I'm about to say next is not going to be an ode to articulators and why the one I use is best. Bluntly, all articulators on the market are basically the same thing, no matter how simple or complex. Furthermore, each one of these articulators incorporates the same mistake into their design. They all accept the maxillary arch as it presents clinically, using teeth as part of the reference for mounting the cast. The aculiner differs as an articulator and analyzing instrument. It is a Class II, non-archon articulator, seemingly with all the sophistication of a rat trap. But the aculiner differs from other articulators in the starting point of its technique. The aculiner begins with mounting the maxillary arch, the foundation of occlusion, to the hamular notch incisal papilla, or HIP plane. A simple, different, and powerful concept. Although Dr. Carlson cites the literature of Dr. Harry Cooperman and relates HIP to other well-established anatomical planes, it is my belief that HIP is more closely related to the plane of the palatine division of trigeminal V2. Although I'm not in the position to prove this statement, conceptually and in the spirit of Dr. Moss, this would make sense. Here's why. First, all anatomical structures need to be related to the neural skeleton. The neural skeleton is primary, with all muscular and osseous growth being a secondary and compensatory result of the nervous system's development. Teeth and dental arches, especially when compared to nerves, are the structures of the mouth most subject to change. Consider gross and obvious changes like those seen from dental extractions, but also be aware of the more subtle changes that are the result of deglutition and the specialized respiration known as speech. When we examine our patients, we evaluate them to the ideal standards that we learned in school. Yet, how many patients truly fit those standards? Probably less than we care to admit, since we dismiss many of our less ideal than ideal patients to focus on those who present with problems. With this thought in mind, we must make a slight digression to discuss two important concepts that are integral to the theme of this presentation. Cranial base diagnosis. What is it? Why is it important? Before I answer this, let me acknowledge that I stand on the shoulders of giants. In this talk, I will attempt to give credit where credit is due. Simply put, the pieces of the diagnostic puzzle are not original to me, but the synthesis and overall concept of how they relate might be my contribution to progress in this area. I first learned about the importance of the neural skeleton from two teachers, Dr. Melvin Moss and Dr. James Carlson. Dr. Moss taught of the primacy of the nervous system in growth and development, and Dr. Carlson wrote and lectured about a simple but powerful articulator. Just to stop you from what you might be thinking, what I'm about to say next is not going to be an ode to articulators and why the one I use is best. Bluntly, all articulators on the market are basically the same thing, no matter how simple or complex. Furthermore, each one of these articulators incorporate the same mistake into their design. They all accept the maxillary arch as it presents clinically, using the teeth as part of the reference for mounting the cast. The aculiner differs as an articulator and analyzing instrument. It is a Class II, non-archon articulator, seemingly with all the sophistication of a rat trap, but the aculiner differs from other articulators in the starting point of its technique. The aculiner begins with mounting the maxillary arch, the foundation of occlusion, to the hamular notch incisal papilla, or HIP plane. A simple, different, and powerful concept. Although Dr. Carlson cites the literature of Dr. Harry Cooperman and relates HIP to other well-established anatomical planes, it is my belief that HIP is more closely related to the plane of the foramen connected to the incisal and greater palatine nerves. portions of the palatine division of the trigeminals V2. Although I'm not in a position to prove this statement, conceptually and in the spirit of Dr. Moss, this would make sense. Here's why. First, all anatomical structures, including functional spaces, need to be related to the neural skeleton. The neural skeleton is primary, with all muscular and osseous growth being a secondary and a compensatory result of the nervous system's development. Teeth and dental arches, especially when compared to nerves, are the structures of the mouth most subject to change. Consider gross and obvious changes like those seen from dental extractions, but also beware of the more subtle changes that are the result of deglutition and the specialized respiration known as speech. When we examine our patients, we evaluate them to the ideal standards that we learned in school. Yet, how many patients truly fit those standards? Probably less than we care to admit, since we dismiss many of our less than ideal patients to focus on those who present with problems. With this thought, we must make a slight digression to discuss two important concepts that are integral to the theme of this presentation. Cranial base diagnosis. What is it? Why is it important? Before I answer this, let me acknowledge that I stand on the shoulders of giants. In this talk, I will attempt to give credit where credit is due. Simply put, the pieces of the diagnostic puzzle are not original to me, but the synthesis and overall concept of how they relate might be my contribution to progress in this area. I first learned about the importance of the neural skeleton from two teachers, Dr. Melvin Moss and Dr. James Carlson. Dr. Moss taught of the primacy of the nervous system in growth and development, and Dr. Carlson wrote and lectured about a simple but powerful articulator. Just to stop you from what you might be thinking, what I'm about to say next is not going to be an ode to articulators and why the one I use is best. Bluntly, all articulators on the market are basically the same thing, no matter how simple or complex. Furthermore, each one of these articulators incorporates the same mistake into their design. They all accept the maxillary arch as it presents clinically, using the teeth as part of reference for mounting the cast. The aculiner differs as an articulator and analyzing instrument. It is a Class II, non-archon articulator, seemingly with all the sophistication of a rat trap. But the aculiner differs from other articulators in the starting point of its technique. The aculiner begins with mounting the maxillary arch, the foundation of occlusion, to the hamular notch incisal papilla, or HIP plane. A simple, different, and powerful concept. Although Dr. Carlson cites the literature of Dr. Harry Cooperman and relates HIP to other well-established anatomical planes, it is my belief that HIP is more closely related to the plane of the foramen connected to the incisal and greater palatine nerves, portions of the palatine division of the trigeminals V2. Although I am not in a position to prove this statement, conceptually and in the spirit of Dr. Moss, this would make sense. Here's why. First, all anatomical structures, including functional spaces, need to be related to the neural skeleton. The neural skeleton is primary, with all muscular and osseous growth being a secondary and compensatory result of the nervous system's development. Teeth and dental arches, especially when compared to nerves, are the structures of the mouth most subject to change. Consider gross and obvious changes like those seen from dental extractions, but also beware of the more subtle changes that are the result of deglutition and the specialized respiration known as speech. When we examine our patients, we examine them to the ideal standards that we learned in school. Yet, how many patients truly fit those standards? Probably less than we care to admit, since we dismiss many of our less than ideal patients to focus on those who present with problems. With this thought in mind, we must make a slight digression to discuss two important concepts that are integral to the theme of this presentation. To illustrate how we use the aculiner as a starting point in our analysis, let's look at a case study that is typical of the type of patient that can benefit from our diagnostic approach. Meet Carl. Carl came to my practice having received dental treatment for his over 60-plus years on Earth. Candidly, his expectations for treatment were not high, and looking at his dental condition, it would not be difficult to understand why. Fortunately, his periodontal condition was excellent, Carl had no obvious signs or complaints of joint dysfunction, despite the fact that his dental arches were mutilated and his jaw position obviously compromised. First, from the works of Axel Bullman and Ulrich Lotzman in their book TMJ Disorders and Orofacial Pain, The Role of Dentistry in a Multidisciplinary Diagnostic Approach, please understand that there are basically only three types of patients: the normal adapted, the compensated, and the decompensated. The normal would be what we would consider, within a slight range of variation, textbook ideal. Yet, don't the vast majority of patients we see fall more in the category of compensated? Life brings its issues, and most people do not escape unscathed. Secondly, the professional dental practice has four basic areas of treatment responsibility: oral pathology, dental caries, periodontal disease, and temporomandibular disorders. The characteristics of three of these areas can be subjected to digital analysis, with only oral pathology being more analog in nature. Consider that the vast majority of people we see, and that are in some form of health maintenance, are compensated after a successful intervention for the treatment of decay, periodontal disease, or temporomandibular disorder. The class of patients that are most needy of our services are those who have become decompensated and exhibit the signs and/or symptoms of disease. Having objective data will empower us to make better predictions and treatment decisions for both the compensated and decompensated. Here is how Carl presented for treatment. On the top row are the intraoral films, on the bottom row the panoramic X-ray. Here's the Aculiner. The black knobs will give you some guidance as to what it does, and basically that's the ability to position casts in relation to each other and make adjustments vertically, horizontally, and along the rotational central axis. Here's where we start. I'll mark the midline and then place the hamular notch of the maxillary cast on the posterior fence. The incisal papilla sits on top of the more anterior incisal pin. The pin and fence take the cast a uniform 15 mm off the analyzing table. The vertical arm of the articulator is set to MP, or mounting position, and the horizontal element is set to 0 if possible. Mounting plaster attaches the cast to magnetic mounting plate, which attaches to the articulator. Once the maxillary arch is mounted on the Aculiner, what are we looking for? Here, from Dr. Carlson's book, Orthocranial Occlusion in the Aculiner System, we see the effect on the mandible that occurs when there is a distortion of the maxillary dental arch to the cranial base. This picture shows a pitch distortion. Pitch concerns itself with the arch from a sagittal view, refers to the AP orientation of the maxillary arch when viewed in relation to the mounting table. Are the molar cusps higher than the incisors' edges, or vice versa? Roll is concerned with the arch as seen from a frontal view. Referring to the lateral orientation of the arch, are the molars on one side higher than the other, or are they level? Yaw distortions, in my clinical experience, are rare. In fact, I've never personally seen one. But if I did, it would involve the rotation of the entire arch to the left or right as viewed from a superior vantage point. My suspicion is that, due to the manner in which the viscocranium develops, it would be more likely not a growth and development issue, but rather would require a major catastrophe, like an accident involving multiple broken facial bones, to develop a yaw distortion. Next, here's where knowledge of dental anatomy is crucial in understanding what you are seeing. Human beings are incredibly standardized. With slight variation, the anatomical crowns of maxillary central incisors tend to be 10.5 mm in length. There can be variation in length ranging from 8 to 12 mm. The width of the central incisor and the lengths of other teeth will provide guidance to tell you if any given tooth is in variance to the norm. In this case, number 8 had worn down to 6 mm. As Carl's story goes, a local oral surgeon who was involved with this case wanted to extract number 4 due to its being significantly extruded out of the plane of occlusion. Since the tooth had no periodontal involvement and was strategic for bridge construction, the tooth was not extracted. When mounted on the aculiner and crown length measured, the bicuspid was an ideal 8.5 millimeters in length. On the left, tooth number 14 contacts the articulator table and has an ideal 7.5 millimeter length. So to review, this patient had no complaint of pain, TMD, or perio, but compensated occlusion on its way towards decompensation. Not to mention, the car would like to look good for the ladies. So let's see what this arch would look like if the anatomical crowns were their ideal average lengths. Rather than raise my overhead, I personally like to wax up the case on the aculiner with the crown lengths where I want them. When I do this, I know what I'll be getting. Control in a case like this is critical, and basically I do this while watching TV. When the wax-up is complete, I'll take an impression in alginate and pour in yellow stone. I'll do this for the bottom arch too. The case that I send out to the lab will look all like normal teeth, in the desired occlusion. Very stable and not too taxing on anyone's imagination. In other words, what you send out is what you should get back. I will also advise the lab on the cusps I want on the aculiner table. The takeaway here is, as H. James Harrington best said, measurement is the first step that leads to control and eventually to improvement. If you can't measure something, you can't understand it. If you can't understand it, you can't control it. If you can't control it, you can't improve it. After waxing the case up to ideal metrics, is it hard to see how this case might look? Let's take a time out and find out why. You see, back in the time of the grand CR neuromuscular wars of the late 20th century, believe it or not, there was something that everyone could agree on. You have to diagnose the temporomandibular joint before you can proceed to treat the occlusion. But before we do, I want to address something that will probably be a growing concern as we move through this information. You will be seeing a lot of technology, and you might eventually be worried that it looks like it'll take a lot of clinical time to obtain this information. After that, the learning curve of what to do with all this will seem pretty steep. That's a legitimate concern. But it is also what will take you to the top 1% of dentists, if not clinically, at least with understanding how human beings work, how they break, and how to fix them. I will confess that in my early days with this technology, I did spend a lot of time running complete biopacks on patients needing these services. To run a biopack, including EMG, ENG, JVA, and a deprogrammed bite, it could run an hour to an hour and a half. You can get around a personal time commitment since the licensure requirements of this technology allow it to be delegated to your assistants, with the exception of the bite registration. But I'll give you a bigger hint of how to use this equipment efficiently. First, understand the problems that you are treating. You have to do your due diligence. Read, take courses, be committed to the task. Of course, the law and order twist here is that once you start down this path, you will become more focused on these issues, and you will see the world of dentistry with a greater understanding than ever possible before. What goes around comes around. Also, understand that in the early days of this technology, the amount of educational support and our profession's understanding of these problems were both sparse and conflicting. Fortunately, now when you become part of this community, you are exposed to many great, bright people, and help is usually just a course or a phone call away. Ultimately, what happens when you do understand these issues is you can be more selective about what tests you need to run, thus saving time and effort. So back in years past, back when everyone involved with neuromuscular dentistry were all eating out of the same trough, basic neuromuscular technique involved detecting hyperactive musculature with EMG, relaxing those muscles via transcutaneous nerve stimulation, and then capturing a bite relationship with the jaw tracking device. This bite relationship was generated from knowledge of the rest position determined by the jaw tracker. The result of this technique can really be great, and the result of this technique can really be bad. Success with classic neuromuscular technique is highly dependent on the clinician to make the technology work. Additionally, classic CR dentists screamed that the TENS bite typically resulted in a down and forward bite relationship, thus taking the condyles out of the centric position down the eminence. There was a lot of bickering about condylar position. Fortunately, the problem was ultimately solved, not by a dentist, but someone that I would consider a genius, John Radke. John and his group developed joint vibration analysis, or JVA technology. JVA is a brilliant way of determining joint health, but it is also something that should help unite dentists for a better understanding of temporomandibular joint pathology. Let's take a time out and find out why. You see, back in the time of the grand CR neuromuscular wars of the late 20th century, believe it or not, there was something that everyone could agree on. You have to diagnose the temporomandibular joint before you can proceed to treat the occlusion. But before we do, I want to address something that will probably be a growing concern as we move through this information. You will be seeing a lot of technology, and you might eventually be worried that it looks like it'll take a lot of clinical time to obtain this information. After that, the learning curve of what to do with all this will seem pretty steep. That's a legitimate concern, but it is also what will take you to the top 1% of dentists, if not clinically, at least with understanding how human beings work, how they break, and how to fix them. I will confess that in my early days with this technology, I did spend a lot of time running complete biopacks on patients needing these services. To run a biopack, including EMG, ENG, JVA, and a deprogrammed bite, it could run an hour to an hour and a half. You can get around a personal time commitment since the licensure requirements of this technology allow it to be delegated to your assistants, with the exception of the bite registration. But I'll give you a bigger hint on how to use this equipment efficiently. First, understand the problems that you're treating. You have to do your due diligence. Read, take courses, be committed to the task. Of course, the law and order twist here is that once you start down this path, you'll become more focused on these issues, and you'll see the world of dentistry with a greater understanding than ever possible before. What goes around comes around. Also, understand that in the early days of this technology, the amount of educational support and our profession's understanding of these problems were both sparse and conflicting. Fortunately, now, when you become part of this community, you are exposed to many great, bright people, and help is usually just a course or a phone call away. Ultimately, what happens when you do understand these issues is you can be more selective about what tests you need to run, thus saving time and effort. So back in years past, back when everyone involved with neuromuscular dentistry were all eating out of the same trough, basic neuromuscular technique involved detecting hyperactive musculature with EMG, relaxing those muscles via transcutaneous nerve stimulation, and then capturing a bite registration generated with the TENS stimulation. This bite relationship was generated from knowledge of the rest position determined by the jaw tracker. The results of this technique can really be great, and the results of this technique can really be bad. Success with classic neuromuscular technique is highly dependent on the clinician to make the technology work. Additionally, classic CR dentists screamed that the TENS bite typically resulted in a down and forward bite relationship, thus taking the condyles out of the centric position, down the eminence. There was a lot of bickering about condylar position. Fortunately, the problem was ultimately solved, not by a dentist, but by someone that I would consider a genius, John Radke. John and his group developed joint vibration analysis, or JVA technology. JVA is a brilliant way of determining joint health, but it is also something that should help unite dentists for a better understanding of temporomandibular joint pathology. Let's talk about joint vibration analysis. Apparatus-wise, joint vibration analysis, or JVA, comes in two flavors, JVA Quick and JVA JT for jaw tracker. The model on the left demonstrates the typical setup for JVA Quick. JVA Quick simply uses the accelerometer here seen placed over both joints and the amplifier box, where on the right the jaw tracker is added. Both JVA Quick and JVA JT can provide full diagnostic information. but typically JVA Quick is used as a screening device. As with many things in life, sometimes you have to give up something to get something. With JVA Quick, in order to have the convenience of not setting up the jaw tracker, you have to be more technique sensitive and conscious of your patient's ability to open and close in coordination with the metronome of JVA Quick. If patients are not consistent in a rhythmic opening and closing, it becomes slightly more difficult to interpret the data. With JVA-JT, since you know exactly where the vibration occurred in the cycle of opening and closing, many clinicians are more comfortable with relating the vibratory pattern with when in the cycle the event occurred. The JVA principle is simple. Healthy joints will exhibit a full, unrestricted range of motion, typically over 40 millimeters when measured on a sagittal slant, and they make no noise. All parts glide over very slick synovial fluid, and a healthy joint basically doesn't have any vibration-inducing friction. When joints are subject to pathological processes like macrotrauma or microtrauma, there are physical changes in the anatomy and physiology of the articular disc, which then cause it to make noise. This noise, or vibratory pattern, will obey the laws of nature and be very specific to the physical properties of the joint damage. Not to get too detailed in discussing how this damage is classified, but very simply put, a joint damaged from microtrauma will typically become rougher on its surface, looser as ligaments become elongated, eventually displaced or dislocated, and ultimately frictional forces may result in bone-on-bone contact. Conceptually, for the sake of understanding the pathology, we stage the levels of breakdown. JVA is able to record and document the vibrations from both joints simultaneously. This data is then available for interpretation. The technique and nuances of how this data is interpreted is the subject matter of its own course. However, let's look at Carl's JVA-JT to see what shape his joints are in after years of obvious attrition and arch mutilation. So here's Carl. Surprisingly, there does not appear to be any physical joint damage. His range of motion is 48 millimeters, well within normal, and there are no significant vibrations coming out of the joint. Is this possible given what we have seen? I believe the answer is yes, and will explain how this can happen given other information I've gathered on Carl. But for now, understand that how he compensated to be able to bring his teeth into maximum intercuspation helped maintain his temporomandibular joint health. For comparison, let's look at a trace that shows what joint pathology might look like. Here's Florence. She is no longer with us, but at the time of this trace she was 87 years old. As you might guess, given her time in history, she was missing several posterior teeth, had some decay and perio issues which required periodic attention, but she was relatively compensated in those areas given periodic care. Further, she had no TMD complaints, but I will tell you that you could hear her open and close from across the room, and her ability to open was restricted. Are there TMD issues here? Is this a TMD patient that requires treatment? Let's mark off some vibrations. Looking at this trace, I see several vibrations within the open-close cycle. There's a mid-cycle opening event, followed by a late opening event, followed by a mid to late closing event. This is all pretty busy. What I'm going to do is mark off similar events for analysis. When I do this, I'm interested in several things, but before you're even trained in data interpretation, intuitively you should be able to distinguish several characteristics of all these squiggles. First, there's the timing of the event. When does it happen? Early, mid, or late? Does it happen on the open, close, or both? Second, what about the amplitude? Is this a big squiggle that fills the screen, or a little sawtooth pattern that barely breaks away from the line? How long does the vibration last? Does it seem to go on forever, or occur in the blink of an eye? Is this vibration consistent or repeated? Finally, how would you describe the quality of the vibratory pattern? S-shaped, sawtoothed, open, closed? To help understand the data, bioresearch studied many patients and set some standards on data interpretation. If you look to the data screen on the upper right, for those more number-oriented,
You will see how the program will capture and quantify the raw data that is displayed to the left and below. The total integral represents the total vibration coming out of the joint. From this, a certain amount of the vibration will be coming from soft tissue, less than 300 Hz, and some from hard tissue, greater than 300 Hz. There will be a relationship between how much of the noise is soft tissue and how much hard tissue. This is the ratio. And finally, there are other data points like peak amplitude, peak frequency, and median frequency that provide additional information of interest. For example, in Florence's case, a peak amplitude of over 6 would tell me, having never seen this patient, that she had a severely noisy, reducing disc that I could hear from across the room. Discs with peak amplitudes of under 6 might be heard by the patient, but might not be as obvious to the clinician. How reliable are your patient's reports of what they hear in the joints? How do you know if the problem is on one side or both? Can you take a stethoscope or Doppler and listen to both joints at the same time? How do you record your findings for future review? Here's an example where it wouldn't be a surprise if the patient reported clicking in both joints. However, I can definitely tell you that there is only one joint that reduces, and that is the right side. Not to make this a JVA lecture, but you need to know about the brilliant design of this technology. Recall that although embryologically the mandible is derived from two separate parts that join in what becomes a synostosis, the mandible is functionally one bone. As such, vibratory patterns can be transmitted from one side of the jaw to the other. This phenomenon is called transference. In JVA, this is important in that not only does it help differentiate where the source of the problem comes from, but it also allows us to stage the degree of disc displacement as to being anterior or more anteromedial. This has consequences in developing our prognosis for treatment success. Bioresearch has done even more of the heavy lifting and provides a handy algorithm for data interpretation. This is provided simply as a guide. You would be well reminded that this technology does not provide a diagnosis, but serves as an aid in providing a diagnosis after all relevant data has been gathered. Let's look at the data flow that JVA provides. Basically, JVA works when 5 pieces of the clinical puzzle come together. JVA can provide 4 pieces, you provide 1. As you can see, when you know the total integral, the range of motion, the amount of greater than 300 Hz vibrations, and the ratio, JVA can point you in the right direction to make your clinical assessment. What you must bring to clinic is a full understanding of the TMD knowledge base. What I'll be discussing briefly at the end of this talk is how we can help speed up your learning curve on this technology. Pillar 3. Surface electromyography. We need to stray from Carl's case for one more moment to cover another important piece of equipment helpful in understanding our occlusal needs patients. As I previously mentioned, as you become more knowledgeable and secure with these technologies, you know when and which of them you need for appropriate clinical evaluation. In Carl's case, I felt comfortable in that I had a mutilated dentition and healthy joint. This is pretty much a green light to proceed with treatment. Efficiency in treatment is always on every dentist's mind, but what I hadn't mentioned was that Carl travels over 900 miles to get to my office, and when he's here, I get 2 to 3 days to work my magic. Knowing this, the question that you should, or probably are asking yourself, is this dentist crazy, just reckless, or very confident in his technique? The answer is probably a little of all of them. Bluntly, if you're faint of heart, not truly committed to your profession, you should stick to MOD amalgams, the occasional implant, and perioscaling. When your patients have these types of problems, find the person that has made this commitment and refer. If you become trained as a young dentist, you can have a professional lifetime of practicing at dentistry's highest level. You will have a better understanding of practice and need less excuses when things don't go as expected. If you're an older dentist and you've been paying attention to what you've been doing over the years, you'll probably have a lower learning curve to incorporate this technology due to your depth of experience. I made this commitment in 1990 and never looked back. So with that thought in mind, let's look at electromyography. Meet Arlene. Unlike Carl, Arlene is my neighbor. She just walks across the street to get to my office. Now, in the spirit of full disclosure, I must tell you two things. One, for the sake of illustrating this lesson, Arlene is a composite of several patients, but the basic story and data are real. And two, I have a home office. This is relevant in that home offices typically have very restrictive zoning requirements. It is not hard to violate such restrictions. Therefore, even if you hated all your neighbors, a good neighbor policy is crucial to staying in the home office business. Fortunately, I like Arlene. She's good people. For most of 20+ years, she's been my neighbor and my patient. The home office business model requires a delicate balance of being available to those who seek your help, but not seeming solicitous. More importantly, when treating neighbors, you could find yourself actually living with your mistakes if you don't know what you're doing. You do not want problems in your own backyard. But for the 20 years plus I've been Arlene's dentist, it's been easy, since she's basically a health maintenance patient. However, down the road, and not long after the ink had dried on our divorce papers, Arlene started experiencing what became vague but chronic facial pain. Not dental and not temporomandibular joint pain, just that vague pain that brings these types of patients to seek treatment. Now, if we were practicing back in the 1980s, the diagnosis for her problem would have been simple. At Columbia, the well-respected and loved Dr. Joe Marbach might have assured me that this was some sort of typical female midlife crisis, a behavioral problem, not a dental problem. He, Sam Dworkin, Charles Green, and that camp had, after all, presented enough smoke and mirrors to co-opt the majority of grant money available in support of their behavioral model of TMD and myofascial pain. But fortunately, this was the year 2011. We know better. Yes, there are often behavioral components to facial pain patients, but which comes first, the chicken or the egg, the anxiety or the pain? After listening to her symptoms, basically vague pain on her left, I rechecked the teeth that I was also familiar with. Virtually no restorative issues worth noting. This was not an endodontic problem. Her periodontal condition was that of a 20-year-old, no pockets or gingival inflammation. Next, and this is probably heresy, I did not poke or squeeze her muscles. My personal experience and opinion is that when you're able to use electromyography, this sort of exercise is basically a waste of time. Whereas physical examination of the head and neck muscles may reveal important diagnostic information, the nature of this process is the worst thing that I can say about dentistry. It's analog. That's right, analog. Subject to all the problems and prejudices of the examiner and patient. How hard did you squeeze? What was that patient's pain threshold calibration? Did you examine the correct muscle? Remember the days when some sage professor stuck his or her pinky behind the maxillary tuberosity to demonstrate that patient's spastic lateral pterygoid? And for those who still believe, you should know it's not possible to reach the lateral pterygoid. The muscle in question was actually the tendon of the temporalis. What I am going to do is take diagnostic models, mount them on the Aculiner, and then do a complete biopack study. Remember, once we eliminate everyday dental problems from the picture, we virtually always start with the joint. Let's look at Arlene's JVA. What are we looking at with this joint? Is it normal, adapted, and without issues? Obviously not. In fact, there is a mixed bag of vibrations. Let's take a look and sort them out. The first set of vibrations are seen on mid-opening, and candidly, this is a tough one, because when you look at the total integral, it is just past the threshold of 20. As objective as this technology is, here's where you need to apply some gray matter to the problem. You see, in taking 5 readings, and I like multiple readings to be more average or representative, the first 4 are sub 20, and only on the last reading do you go over the threshold. If we were to look at the first 4 only, and a ratio of 0.44, we might conclude that this vibration represents mild DJD, and this would make sense. Yet, if we add the 5th reading for a total integral of 20.7, the algorithm would suggest ligament laxity or partial disc displacement with early DJD. Before we come to a conclusion, let's look at the next vibration. Here I start to mark off 4 vibrations that were found later in closure. However, when taking the second reading, The BioPack algorithm stopped to ask me if, in fact, I was looking at a mirror image. With this slide, you can see that BioPack quantifies the amount of vibration transference. This amount is significant because it is the harbinger of how much the disk has displaced anteriorly or anteromedially. Were we to have ignored BioPack's mirror image warning and clicked No, the reading for the left joint would appear, and you might think that the left side joint had issues too. This is not the case, even though the patient's symptoms are on the left. Rather, let's analyze the right side and see what we have first. With a total integral of 90.7, this puts us firmly in the third category of total integral readings. Next, consider the range of motion. Over 50 millimeters on the slant is great. What about the ratio? At 0.08, apparently when there is closure, the condyle reduces off a healthy portion of the disc apparatus. With a peak amplitude of 6.8, we hear the reduction on the right when our lean closes. When we put the data together and try to make sense of the clinical picture, we arrive at the conclusion that the right joint has disc displacement with reduction and signs of early degenerative joint disease. But wait, wasn't her problem on the left? Let's see, finally, what the electromyography shows. Here is her resting EMG trace. Like JVA, EMGs come in two flavors, resting and functional. Despite the label resting, both types of studies provide information about muscular function. Functional EMGs are more obvious in this respect, in that you will be asking your patients to perform certain tasks like clenching, swallowing, tapping back teeth together, etc. But resting EMGs also provide information on how muscles function, only it's after the fact. Classic examples are seen in chronic clenchers having bilateral hyperactive masseters, and patients with overclosed mandibles exhibiting bilaterally hyperactive temporalis muscles at rest. In considering EMGs, it would be recommended that muscle anatomy and physiology be reviewed. Here we have marked data. When you look at the raw data, look for uniformity in appearance. I have moved the cursor randomly to the center, pressed F5 to widen my sample, and marked the area. On this sample, you will see the results in the upper right window. Even without understanding the parameters of the data, BioPack gives you a heads-up warning that bad numbers are red, good numbers are green, and cautionary data is in yellow. For Arlene, the only numbers that were not hyperactive were her sternocleidomastoids, so at least she has good head posture. When looking at the remaining temporalis, masseters, and digastrics, we want to analyze them in terms of symmetry and synergy. Are like muscles mirror images in balance, symmetrical? Are the muscles of the left or right well balanced, synergistic? For Arlene, the elevator muscles of the left were very hyperactive, relatively twice as high as the right. The depressor muscle activity is the opposite to the elevators in the same proportions. This is where everything gets interesting. Long-standing disc damage on the right, symptoms and hyperactive muscles on the left. Why and what to do. Do certain occlusal schemes result in higher incidences of TMD? What about bruxing in TMD? Looking carefully at her casts, you see someone with no history of orthodontics in near ideal, socked-in, class 1 occlusion and good midlines. Look at the incisors and cuspids. See any wear? I can tell you that the upper and lower central incisors are near perfect 10.5 and 9 millimeters respectively. This is most likely not a case where bruxing is the culprit in causing disc displacement. There's no history of trauma, so what gives? Let's look at the aculine mounting of the maxillary cast. This patient has a basic roll problem, with only the teeth on the left in contact with the analyzing table. The right side is a full 1 millimeter off the table. Normally, I would expect the right side to be more hyperactive at rest, since the mandible needs to work harder to reach maximum intercuspation on the right side. But with bilateral masseters in hyperactivity, her admission of high life stress levels, I would hypothesize that under the force of the chronic clench, the left is exposed to a greater isometric force. It is doing more work, thus creating the relative higher level of hyperactivity at rest when compared to the right. This higher level of activity might result in a greater potential for muscle spasm and lower thresholds for pain. So now we have two good, documented reasons for this patient's problems. Is it the disc, the muscles, or a combination of the two causing the problem? Given the disc is probably a more long-standing problem that has adapted, and that the stress-generated clenching is recent, my money is on the muscle. Okay, now we've started to develop some nice data, greater insight, and perhaps a hypothesis on how all this came to be. What's next? The last part of the biopack is the jaw tracker. Here I will show you how I confirmed some of my suspicions concerning Arlene's problems. After that, I will return to Carl to finish out his case study. The seronathograph or jaw tracker has had many incarnations, but unlike JVA and EMG, there's only one flavor. Here the jaw tracker is shown from the front, with the position of the magnet being displayed. The jaw tracker uses the Hall sensor effect to track this magnet through time and space. The magnet is very light, and there are no clutches or devices that might influence jaw movement. Here's Arlene's initial jaw tracking, or EGN, study. The computer tracks the movement of the magnet throughout time and space. What we are studying is her range of motion in sagittal and frontal views, the velocity of opening and closing, how smooth is that pattern of motion, and whether there are deflections or deviations in the open-close cycle. Here you can see that despite her joint problem on the right, the pattern and velocity of opening and closing is excellent, greater than 350 millimeters per second. There is no crossover pattern which might indicate anterior misguidance, and the amount of deviation to the right on opening is just slightly above the accepted norm of 3 millimeters. Given what we know about her right disc, this makes sense. This trace reveals no dysfunction. Whatever disc problem she might have, it appears to be well compensated. All in all, this is looking like a muscular problem. The next step in the protocol is to deprogram the muscles via the transcutaneous nerve stimulator, or TENS device. Although there are a number of ways of deprogramming the bite, 30 to 45 minutes with the TENS consistently does the trick. For those unfamiliar with transcutaneous electrical nerve stimulation, or TENS, let me warn you, this is the most dangerous technology in dentistry today. The reason that it is so dangerous is that the mere mention of it to those unfamiliar or have never used it will launch a lengthy tirade of reasons why it is no good for use in dentistry. My personal favorite reason is that it can't relax the lateral pterygoid, and that's why you always get a down and forward bite. When we return to Carl's case, I will show you how this statement is just not true. But for now, I will tell you why I like TENS as part of my technique. First, it is an accepted modality in medicine. I can't tell you how many times my physical therapist's electrical stimulator has saved me from my spastic back. Second, where you can use intraoral appliances to deprogram the bite, these generally take longer and are not uniform in application. Third, And this will sound like heresy to some. I do not believe that TENS works by relaxing the muscles of mastication. Most patients do show lower EMG activity post-tensing, but a small group of patients react to the electrical stimulation with increased muscle activity. The difference in the two groups when taking a bite registration? None. Having seen this over the years, I came to the conclusion that it is not important if TENS relaxes the muscles, but rather it operates by deprogramming the neural engram for the habitual path of closure and replaces it with the uniform electrically pulsed trajectory. Finally, TENS is a semi-active registration technique. I feel that I am not interfering with or unduly influencing the patient's natural physiology during closure. The possible reaction to my actions in obtaining the registration are pretty much factored out of the equation. Here's a trace from a TENS bite. The upper left screen tracks the path of the magnet over time in the sweep mode. The three lines represent the open-close in green, anterior-posterior movement in red, and lateral motion in yellow. This trace developed over time. In this case, the trace happens over 14 seconds. Now in the lower right, we see the same trace, but the 14 seconds are converted into an XY axis display. Here's how the TENS versus habitual bite trace develops. Looking more closely at this trace, we can see that the path of the magnet is tracked both on the sagittal and frontal view simultaneously. The red and green lines represent opening, while the blue and purple show closing. The grid is marked in 1 mm squares. What this screen shows is the comparison of the TENS-induced path of mandibular movement versus the habitual path of movement. Let's see how this works. Looking more closely at this trace, we can see that the path of the magnet is tracked both on the sagittal and frontal view simultaneously. The red and green lines represent opening, while the blue and purple show closing. The grid is marked in 1 mm squares. What this screen shows is the comparison of the TENS-induced path of mandibular movement versus the habitual path of movement. Let's see how this works. Looking more closely at this trace, we can see that the path of the magnet is tracked both on the sagittal and frontal view simultaneously. The red and green lines represent opening, while the blue and purple show closing. The grid is marked in 1 mm squares. What the screen shows is the comparison to the TENS-induced path of mandibular movement versus the habitual path of movement. Let's see how this works. Here's how the TENS versus habitual bite trace develops. The display shows the TENS path of closure. The electrical stimulus is discontinued and the patient instructed to bite on your back teeth. Tap, tap, tap. Now protrude. One of the great things about this technology is that you can map out your goal for where you want your bite to be. In the record mode, the trace with the desired TENS versus habitual bite is brought onto the screen in the XY mode. The screen is marked on the TENS closure trajectory where the treatment position should be on both sagittal and frontal view. In this example, I re-established the bite 1.2 mm vertically and moved it forward 0.6 mm. In the record mode, you can calibrate the tracker and capture the bite registration as planned. So to wrap up Arlene's case, we made her a mandibular orthotic, a demand appliance positioned to the engineered bite registration. She was instructed to wear it as much as possible, except to eat. This was to reprogram muscle activity and decompress the right joint. Within the week, she was feeling better. The orthotic was worn for less than 6 weeks. She was gradually weaned off its use as the 6th week approached. There are no plans for crown and bridge or ortho as a permanent solution. Rather, after this intervention, the compensating mechanisms that worked in the past re-exerted their influences, and she keeps the orthotic for future use if needed. Hopefully you still remember Carl. Let's look at his EGNs in comparison to Arlene's. Mutilated dentition versus near textbook perfect. What happens to his function? Does TENS deliver the fabled down and forward bite. Let's see his data. Question: how has Carl kept himself out of major TMD trouble? Answer: compensation. Let's look at the velocity screen. These are very low readings for someone who is instructed to open and close as quickly as possible. The reason is not due to joint events either. There are no sudden disruptions in the velocity pattern that would be typical of the disc interfering with normal translation. Rather, my suspicion would be that this is someone who, due to a marginal occlusal scheme, must be guarded as to where he bites. Therefore, bradykinesia is the rule. On sagittal view, for someone with so many missing posterior teeth, I would normally be looking for more of a crossover pattern, which might indicate a distalized mandible from a lack of posterior support. But Carl probably saved himself by staying reduced onto the disc and terminating in an edge-to-edge occlusion. The deviation to the right, most likely due to having more occlusal surface to contact with the lone molar, number 31. Movement to the right would be a more normal path for someone with no options for occlusion on the left. Approaching occlusion from the buccal aspect of number 31 would be more natural than opening to the left and striking this tooth from the lingual. Here, in the upper left sweep screen, we follow the tensed generated path of closure. Starting at 0, follow his deprogrammed path, his habitual path, and finally, Carl slides his lower jaw forward, bringing his anterior teeth edge to edge. Where does our TENS registration take us? Is this bite down and forward? Absolutely not. Carl's deprogrammed trajectory is basically his habitual trajectory. The only difference is that the estimated terminus of occlusion from the deprogrammed path is 4.5 millimeters vertical and slightly more than 1 millimeter lateral from habitual occlusion. Here's where I tip my hat to Dr. Hank Shimbashi and his work. Recall how long his central incisor was? Take that 6 millimeter worn maxillary central incisor and add 6 millimeters for his worn mandibular incisor. The 4.5 millimeters of lost tooth structure predicted by the deprogrammed bite, and 1 millimeter of normal overbite, since he was edge to edge. The sum is 17.5 millimeters, or 5% from the sum of measuring from cervical terminus to terminus of a 10.5 millimeter maxillary central, meeting with a 9 millimeter mandibular central incisor, and 1 millimeter of overbite. The amount of overbite will vary according to occlusal class, but a way of evaluating this variation would be to assess the posterior occlusion. For example, maxillary and mandibular first molars have 7.5 millimeter anatomical crowns. If they met cusp to cusp, the cervical terminus to terminus would be 15 millimeters. Take away a millimeter for the cusp to fossa relationship, and that measurement is more like 14 millimeters from anatomical crown's end to end. When attempting to estimate the amount of vertical restoration needed in a case like Carl's, realize that nature provides the numbers. You need only take the time to record and understand them. On the top, we have working casts with the bite finalized on the jaw tracker. Using impression putty and the Aculiner, the mutilated lower arch can be normalized in terms of the curve of Spee, simplifying the registration process. On the bottom are casts with the putty removed, but still in the desired treatment position. This case will need temporaries. Presto! Now you are ready to start prepping some teeth. When you know where you're going to finish, all that needs to be done is fill the space with teeth. We prep the teeth. You might ask, why not leave some unprepped teeth to help with the bite registration? Aren't you afraid that the bite might be compromised? In brief, no. Once the teeth are prepared, the first try-in of the temporaries are with Regisil. Temporaries are seated in full occlusion, top and bottom, with Regisil as a test relining material. We monitor to see how the occlusion looks, patient feels, and the inside of the temporaries are inspected to be sure that the tooth reduction was adequate and not hanging the temporaries up from seating fully. When this has been accomplished satisfactorily, the temporaries are relined with acrylic resin, trimmed, and polished. Here you have a view of the underside of the laboratory fabricated temporaries, in this case Biotemps by Glidewell Laboratory. In prepping teeth in a case that is overclosed, A lot of occlusal reduction has already been done from wear. The clinician needs to be conscious of this situation as not to over-reduce the occlusal aspects of the tooth and negatively impact retention or pulp encroachment. Here are the before and after photos on the day of the preparation. Full arch impressions are taken, and preliminary bite registration obtained off the Aculiner mounting is relined. This is the untrimmed maxillary cast prior to pinning. Moving from this step to complete articulated models requires a slight trick of the trade to make the transition to the laboratory phase. This case has been built on the initial diagnostic models. The concern that I have is that subsequent models may have slight variance on the HIP mounting, the hamular notch might not get captured in the final impression, and that when the pin model is fabricated, typically the pallet is removed. Therefore, to keep everything under control, I use the following technique. A putty index of the original diagnostic model's pallet is made, tooth areas cut out, and positioned on the Aculiner table exactly as the original was positioned. The new, untrimmed full arch impression is securely placed on this index and glue gunned to place. The base of the full arch impression is lightly vaselined, then luted to the mounting plate and Aculiner. Next, the Aculiner vertical and horizontal elements duplicate the original diagnostic mounting and are locked in. The rotational element is loosened such that the cast can be rotated away from the table or be closed and parallel to the table. With the model rotated away from the table, a putty squared that is indexed to the table is made such that impression material can be added to its surface. The full arch cast can be rotated into this material and the relation of the incisal and occlusal surfaces of the preparations captured in the index. When the pinned model is created, the model can be seated into this index and luted to the mounting plate and articulator. Untrimmed models on upper row, completed models with crowns seated nicely on Aculiner analyzing table. Bottom row shows occlusal views. Case mounted on articulator and case in the mouth with Valplast partial denture seated. Before and afters. Please realize this is the result of 3 visits. Visit 1, records, diagnosis, and treatment planning. Visit 2, preparations, impressions, and temporization. Visit 3, case seated, adjusted, and cemented. When undertaking a project of this magnitude, care is taken at each step to be precise in technique. Errors at any step can doom the final outcome. But the truth of the matter is that no matter how careful the clinician is in their efforts, at the end of the day, you are treating a biological organism that has amazingly complicated feedback mechanisms. As every restorative dentist has most likely noted sometime in their career, the mouth is the final articulator. To be totally truthful, when this case was seated, there were seemingly big problems with the bite. It just wasn't right. Was this the time to panic? No, it was time to break out my T-scan to analyze the force and timing of the bite. T-scan was developed in the 1980s. TechScan's dental division provides but one of many uses for plastic wafers containing pressure-sensitive ink to record the measurement of force and timing. The unique design of this technology recreates a maxillary arch on a computer screen, and after the patient bites into the wafer several times to condition it, their next bites may be captured, recorded, and analyzed. More so than articulating paper, which may or may not show where teeth are contacting, T-scan can virtually guide the clinician as to what the patient is feeling. There are several programs for analyzing occlusion and disclusion timing, but in Carl's case, due to his mostly only having an anterior occlusion, I'm going to use T-scan to determine and refine his center of force. The center of force is extremely important in that if you look at how teeth are angled in the mouth, it becomes readily apparent that on maximum intercuspation, or a clench, the force of that bite should be dissipated through the palate into the vomer and ethmoid bones. Clinical experience has shown that the closer the distribution of force is to 50-50 from left to right, the more comfortable the patient will feel. The timing of this distributed force is also important. Typically, there will be anterior contact first, which serves to guide the mandible to its final position in maximum intercuspation. This device has many practical day-to-day applications, but when doing the big cases, it is a lifesaver. Let's look at some data. The upper left screen is the 2D, the upper right, the 3D view. The lower left shows the force generated by the right in red, the left in green, and the total force in gray. The left axis is the percent of total force, and the bottom axis is the time in seconds. When we run this movie, we see that the force starts and stays on the right, developing a long tail trajectory, and that at 80% force, 65% of the occlusion is on the right compared to 35% on the left. This would not be totally unexpected in that Carl has less natural teeth on the left, but on the other hand, that difference is only one tooth. My strategy was to start with the partial denture in place as to give the fullest sense of occlusal support. After several adjustments, guided by several readings and Carl's approval, here's what we got. This movie was made at the insertion visit. All crowns were seated and the partial placed. The patient is then instructed to bite on the T-scan wafer 3 times. This exercise conditions the sensor for the actual recordings. As previously mentioned, Carl's bite had the potential for disaster. What could have made things particularly bad was his inability to tell me where to start adjusting his bite. Fortunately, I basically don't need his input. I've got force and timing data. Of course, this is not to say that I'm not grateful for his approval as I adjust the case, but honestly, it's just the icing on the restorative cake. I am looking for several things from this reading. Where does the occlusal force begin? What is the trajectory of force development? And how even is it as it approaches 80% of total force? Here you can graphically see the improvement as the trajectory heads towards center. At the 80% of force mark, the balance improves to be 47 to 53%, far more even, as Carl agreed. Plus the occlusion time required to achieve this result was halved, beginning with a pre-coronoplasty time of 1¼ seconds to a post-op result of about a ½ a second. With the partial denture out of his mouth, the study is repeated. At 80% force, we achieve a 49 to 51% left-right balance in 0.49 seconds. This result is slightly more anterior than we would normally like, but considering that we mostly have anterior teeth meeting, this was a result that both Carl and I were happy to achieve. All teeth were permanently cemented after this slight adjustment. Carl will return later in the year to commence implant restoration of the posterior segments. When he does, I will also use T-scan to adjust the occlusal contact to occur just after the natural teeth touch, as to keep the implants functional but lighten their load. I hope that you can see how this dental metric approach makes treating entire occlusions as simple as treating one tooth. So there you have it, 5 relatively new methods for seeing the dental world, moving from analog to digital. But as I originally stated in the beginning of this program, this was not a talk about the instrumentation. These instruments simply convert the world as we know it into a world that computers can analyze and display, thus leveraging our ability to understand nature. The future will bring ever-increasing pressure to evaluate our patients within the medical model. This is a model where more parameters of human anatomy and physiology are measured in order to gather data for diagnosis. As a profession, we also need to move towards diagnostic and treatment methods where we can objectively measure the progress of our treatments and patients' health, or at least figure out why things didn't go as expected. As we bring the curtain down, I would suggest that you are on a professional journey. It probably started in dental school and now continues through your practice. You stop from time to time at the oasis of a continuing education to be nourished and fortified for your travels. The refreshment of knowledge allows you to help the travelers you meet along the way. This presentation was prepared to give you the knowledge that there are methods available to you that will enable you to help those under your care in new, more predictable, and scientific ways. These tools are available to you now. Decades of experience of those who passed before you are also available to prevent you from straying into harm's way. These tools do not dictate how or what to think. There's no prejudice in their application. If your data is obtained correctly, you won't need lies in order to conform to a preconceived belief system. Honestly, on occasion the truth can be a cruel taskmaster, but the truth will keep you free. My hope in presenting this information is that you will move outside your comfort zone, stop looking for the easy answers, and start looking back at the basics. Create your own programs of study: physiology, anatomy, growth and development. Break free of a mechanical dentistry in favor of a more biological and data-based model. Understand that the trigeminal nerve is more important to us than the condyle. But most of all, think. Question what you see and hear, then think for yourself. Not that you should be closed to outside influence, because you need to evaluate information in the context of your personal experience. The metaphor for knowledge acquisition would be that of the over 12 million immigrants that landed on our shores through Ellis Island. They came for a better life. They faced hardships. They worked hard, and eventually their hard work, with the support of their community, helped improve their lives. The curious dark side of this experience was that once comfortable with their situation in life, many became uncomfortable with succeeding generations of immigrants. They seemed so foreign. Public opinion eventually changed, brought about by the very people who came to our shores to restrict future immigrants from coming to America. Ironic, right? Knowledge is that way too. People have problems. Solutions are found for those problems. Knowledge about those solutions is shared, and social networks formed. These groups celebrate their knowledge, but become suspicious and intolerant of those who do not share in their truths. What they don't realize is that there's a big difference between truth and knowledge. Truth is eternal and immutable. Knowledge, on the other hand, has a half-life before it is replaced or modified by other knowledge. Having said this, I will leave you with Stapleton's 4 observations with respect to knowledge. First, you don't know what you don't know. Second, the advancement of knowledge is evolutionary, not revolutionary. Next, knowledge has a half-life. Finally, knowledge is not truth, but truth is built on knowledge. Now, normally I would thank you for your attention, but there's more. As promised, I'm going to touch briefly on some new technology designed to help you organize the data that you need to come to a diagnosis and aid in communicating those findings to your patients, all in a totally automated manner. Introducing the Dental Integra, Integrated Dental Health Scoring System. The Dental Integra is a web-based program designed to help you analyze and report on your patient's decay, TMD, and periodontal disease issues. Using advanced algorithms, the Dental Integra features integrated patient medical and dental histories combined with data entered through the world's first truly smart chart. The result is data-rich health reporting for both doctor and patient, including heads-up clinical statistics and analysis for the doctor, and narrative reports written at layperson levels to transmit findings to your patients. All at the touch of a button, with no more effort than filling out your electronic clinical chart. Of course, this notification is just a tease. I hope that if you've enjoyed this seminar, you will join me for Clinical Dental Metric Diagnosis, Introduction to the Dental Integra.